Let me assure you that there are answers from hospice in relation to the first three of those areas. Hospice can and does foster solutions and concerns about caregiver burden and the cost of care. Across the country, we have done this millions of times. Hospice can and does foster solutions in relation to dignity. There's a wonderful chapter in Mitch Albom's book, Tuesdays with Morrie, in which Morrie describes in a very inspiring way how he learned to accept being cared for in a very personal manner. There's no doubt that hospice can address pain and discomfort. Hospice medicine has led the way in this area for the past 30 years, and now it leads the way with the development of a newly recognized subspecialty called hospice and palliative medicine. With regard to the question of autonomy, this political question is one that we can't solve. Here is Hospice of the Western Reserve's philosophy addressing assisted suicide. We affirm the dignity of life and advocate for patients and family comfort and quality during life's crowning phase. We believe that hospice patients have a right to continue life to the fullest extent possible according to their circumstances, and we believe in fostering opportunities for continuing growth and fulfillment. We further recognize patients' decision-making rights in relation to continuing medical treatment. We do advocate for the right to withdraw treatments whose benefits are outweighed by their burdens. We also support the use of medication to alleviate pain, even if there is a risk as a secondary consequence that the patient may die because of those medicines. Hospice of the Western Reserve does not support assisted suicide or euthanasia. We do understand that some of our patients may request these things. We will not abandon them, but rather will continue to support them, providing them with comfort, including social, psychological, and spiritual support. Thank you.
Thank you, David. We have the opportunity now to engage our panelists in a little internal conversation up here on the stage. And then in about 10 minutes, we'll look forward to conversation with you here in the audience. I think the jumping off point, logically, where I'd like to hear our panelists speak to one another relates to physician-assisted suicide. It is almost exactly a year since the second of our 50 states in the USA voted in favor of legalizing physician-assisted suicide. That is the state of Washington, following in the footsteps of their neighbor, Oregon. And many keen observers of the United States of America often see a movement from left to right across the country geographically. Sometimes I think that if California makes the next move, it may be inevitable that we will see physician-assisted suicide make its way from west to east. So I'd like to hear from the panelists their thoughts about Ohio and physician-assisted suicide.
Well, I can't speak particularly to the Ohio law per se, but from the point of view, certainly of Catholic teaching, and I think from my own conviction, what hospice stands for, I took the notes of altruism, dignity, pain, problems, and autonomy. Those are often the issues why people choose to have physician suicide, because they feel they're going to be abandoned, they're going to be in pain, they will lose control, they don't want to burden their families. I think hospice, personally, I think hospice is a better answer to the question of physician-assisted suicide. On the other hand, well, this is just additional. I heard someone speak about the compromising of physicians in the Netherlands after this law had been in place for a long period of time, that the physicians themselves are being asked to help people die who really are not particularly in a terminal condition, and there's pressure, and the physicians themselves feel a psychological burden having to help people die, in a sense, almost against what they have become physicians to do.
I think it would be very, very, very unlikely scenario for such a law to pass in Ohio, and I base that on experience that we had time and time again through the 80s trying to get living will, trying to get durable power of attorney. Those weren't legal instruments in Ohio until the early 1990s, and there is such a perspective, I would say conservative perspective on this matter in Ohio that I just can't see that ever happening here. On the other hand, there is another state where it's legal, that's Montana, but that wasn't through legislature, it happened through the courts. There is probably an overlap in relation to those who advocate for assisted suicide and where I would advocate for a hospice patient. An overlap probably about 98% of what we would say. It's this final step that hospice will not participate in or support. But the people who are advocating for assisted suicide are basing their advocacy often on circumstances that, as you said, hospice can address. But oftentimes these aren't being addressed in the settings where the patients are. You talk about 300 or 400 consults at the Cleveland Clinic. I imagine that many of those are about these very difficult family issues. And it is a social, it's not just a personal, it's a social decision.
Absolutely. And the ethics consultant at the Cleveland Clinic and I think across the country when involved in these end-of-life cases will often try to help family members say not what should we do with this patient, but what would this patient decide if they could make a decision now for themselves. As you said, to cultivate the moral imagination of family members, of whoever is speaking as a proxy or surrogate, so that they will make a decision that's consistent with the values and wishes of the person if they could make their own decision. And that's the autonomy and our emphasis on autonomy in the United States. It's very difficult to do in practice. People want to make decisions that they want to make even in these situations. So that's an area that I know hospice can help a lot with.
The National Hospice Foundation did a survey in about 1997, and it asked American people, it was a Roper type of survey, do you know what you want at life's end? Yes, I know what I want, 90% of the people said. Do you think you'll get that? And a high percentage, yes. And have you ever talked to anybody about it? About 8% on that survey. So I have a message for the students back here, and that is that it's more important for you as you become young adults to do advanced directives than it is for me. I'm 66 years old, and if I go into a coma and you go into a coma on the same day and nobody can get you out of that coma, you'll be in it a lot longer than I'll be in it. And the cases that have gone to the courts, they're young women. Nancy Cruzan, Karen Ann Quinlan, Terry Schiavo.
Stuart.
I want to make a comment about legalization. I agree with David completely that if you wanted to wreck your political career, get up in the Ohio State Legislature and advocate for physician-assisted suicide. However, there's another way that, that this works, and the example I would give you is Wayne County in Detroit. Remember that Jack Kevorkian was helping patients commit suicide for several years, and he did it with dozens of patients. He didn't do it surreptitiously. He did it blatantly, dumping the bodies in front of the coroner's office and saying, what are you going to do about it? And he never got in trouble for it. He got in trouble when he actually killed somebody, took a film on it and showed it on national television. Pardon?
He did it live.
Yeah.
When he did active euthanasia rather than physician-assisted suicide.
So you could say, if you were a patient and a physician in Wayne County, and your whole family agreed, and you were going to do it in the quiet of your home, that probably you weren't going to get in trouble. And in New York, in Rochester, Dr. Timothy Quill, who's written a lot about this, helped a patient with physician-assisted suicide, wrote about it in the New England Journal, or JAMA, and was investigated by his local medical society and the prosecutor, and nothing ever happened to him. So another way things change is that sort of informal way. Now, I think we're going to see that in parts of the United States. For sure it goes on in Cleveland, but it goes on quietly. The other comment I want to make is about the Netherlands. The Netherlands, first of all, they do euthanize people who aren't terminally ill,